Welcome everyone to our social justice movie night. And I want to thank everyone for being with us tonight. The movie was The Providers. So I hope everyone has enjoyed viewing that movie. We have an excellent panel to have some discussion with tonight. And I will turn it back over to you guys and to our moderator for tonight, which I believe is Teresa Villeron.
Hi everyone, my name is Teresa Villeron. I'm the chair of the Professional Nursing Practice and Advocacy Cabinet. We welcome you to our 5th installment of our social justice movie nights. They've been very good discussions, and tonight's not going to be any different. I'd like to introduce our panelists. Dr. Jessica Estes is a psychiatric mental health nurse practitioner who graduated from Vanderbilt University in 2004, then completed her doctorate of nursing practice at the University of Kentucky in 2013. She is ending a 2-year term as the executive director for the Kentucky Board of Nursing and currently serves as the chief nursing officer for Alaska Behavioral Health. She has provided rural health care in Minnesota, Indiana, Ohio, Kentucky, and Alaska. Welcome, Dr. Estes. Our next panelist is Dr. Sharon Locke. She's a professor and assistant dean of faculty practice at the University of Kentucky College of Nursing. She recently provided leadership over a complex partnership of academic and healthcare partners and was awarded a $1.7 million grant from the Health Resources and Services Administration to enhance the role of the primary care registered nurse in rural Kentucky. Dr. Locke received a doctoral degree in nursing science from the University of South Carolina and a Master of Science and Bachelor of Science in Nursing from the University of North Carolina at Chapel Hill. Welcome, Dr. Locke. All right. So the first question I want to start with, I just want to say that in the last 6 weeks, I attended 2 nursing conferences, and the chats within those conferences were very disheartening. Nurses are really, really hurting out there. And I think a movie that we watched tonight just kind of highlighted, especially in the rural areas where healthcare providers maybe feel very isolated. So the personal toll on the care providers is very evident in the movie. How can we better care for the caregivers, and particularly those who might be isolated in rural areas? Dr. Estes, I'll start with you.
So one of the challenges I think in rural healthcare is many times you might be the solo or maybe one of a few providers. And if you end up being the most experienced provider, then there really isn't any downtime for you. You found yourself on call 24 hours, 7 days a week. And a lot of that has to do with the fact that there just really isn't anybody to reach out to. You know, I use the example of owning my practice in Western Kentucky for a decade. I took my cell phone with me every day, everywhere I went, because it was me. We were in a county where there were no physicians. It was solely APRN run. I was the only mental health provider for many years. And that burden is very, very heavy. And we don't like to talk about those things because the expectation that we set is that we're going to handle it all, right? We're nurses. We can do that. We can make it happen. We shouldn't get stressed out because we chose this. That's the profession that we thought we were going into. But choosing something doesn't mean that it stresses us any less or it hurts us any less. And so we really have to get to the place where we're talking about the fact that that burden is tremendous. Even on our best days, it's problematic, and we've got to increase resources. The mental health impacts on nurses are huge. I had the opportunity this past week to do my CPR recertification, and I was so excited to see them talk about the fact that if you've had to do CPR for the first time on somebody and you lose them, your employer or the people that you're with should suggest that you see a mental health professional to talk about and to process what that's like to lose somebody. 26 years ago, when I started in healthcare, we didn't talk about those things. So we're moving in the right direction, but we have to do a better job.
I agree. Dr. Locke? Same question.
I certainly agree with what Jessica has said. The other thing that I think would help support providers in rural areas is to get more RNs in places like primary care, mental health, that kind of thing. I mean, when you look at, you know, like when you go to your providers, more than likely it's not going to be an RN that gets you into the room and talks to you about all of that. I know in our clinic in Wilmore, we were able to hire an RN, and it makes all the difference in the world. I mean, it's just the type of support she gives our providers, you know, just as far as talking to patients about, you know, whether it's patient education related to nutrition, any of that kind of stuff is, I think, important. But I also think that we would have to raise salary. I mean, you know, that's part of the issue, is that the RNs aren't getting paid to work in primary care, and certainly in rural areas. So I think that's an issue.
So along those same lines, how can nurses advocate or even get involved with policy that can better, you know, the opportunities for nurses to practice in those rural areas? Dr. Locke, I'll start with you.
Well, I think, you know, for lack of a better term, political activism, you know, we just have to get out there and fight for ourselves, you know, because nobody else seems to be doing it for us. So, you know, we need to make sure, you know, people join, you know, K&A, professional organizations, and even if they're not the ones to go to legislative day, at least the numbers are there, you know, so so others can go to legislative day and say, we've got so many thousand of members, and, you know, they're all for getting more nurses into primary care or out in rural areas or whatever.
Dr. Estes, what about you? What do you think?
I would agree with what Dr. Locke said. A lot of the reasons why we struggle to recruit healthcare providers in rural areas is because of salaries. You know, small rural practices cannot compete financially with larger institutions. We sometimes don't even offer the variety of skills that you might see in a larger hospital system. So that's probably one. The second thing is probably the political activity component. You know, the reality is in healthcare, we are very politically influenced, and whether you like it or not, the people that are sitting in Frankfurt and in Washington, D.C. are determining how we get to practice. They determine how we get paid. They determine really the types of patients that we end up caring for. Dr. Locke and I both have been in healthcare long enough that the patients that you would have seen in ICU or CCU, even as soon as a decade ago, we're now seeing in long-term care, requiring greater skill levels, more complexity, more patient touches, but yet we're seeing reimbursement decline over time, given the amount of work that we have to do. So political advocacy, whether we like it or not, your voice has to be heard. If you're not using your voice, you're not truly caring for your patient, because at the end of the day, who knows more about what healthcare needs than you do as the nurse that's providing those services? And that's one of the things that I'll say that I don't think nursing does as well as we could. We're not great at using our collective voices. We struggle to use the volume that we have to articulate what our needs are and what should happen to drive change. If we all could collectively get on the same page, we'd be a force to be reckoned with, because there are more of us than almost any other health professional in the United States. But we got to move that voice in the right direction. And in the same direction, like Dory says, you got to swim the same way. Everybody's got to swim in the same direction at the same time.
That's right. I really appreciate those comments, Dr. Estes, because I really agree with that. You know, there's over 4 million of us, and we do need to be better at having a collective voice. The next question is about mental health. We've seen a lot of mental health struggles for years and years and years. It seems to just have gotten worse, not only for our patients, but for the care providers, which we saw in this movie. How can we improve mental health services, particularly in rural areas? And we also know that farmers struggle with this. So how can we improve mental health services? Dr. Estes, I'll start with you.
So the first thing is we've got to do a better job of exposing individuals to good quality behavioral health services. Psychiatric services are something that you either love or you hate. And what I find is that people don't have a great opportunity to see mental health at its best. You know, it's such a small component of our careers that in our education, that unless you choose that path, you don't get to see what it's really like. And I'll give the scenario. There is nothing more satisfying than a patient coming in with a specific issue that's causing them emotional distress and being able to help them successfully navigate the landmines and come out on the other side better than they were before. And I say all of this because at the end of the day, the issue is access. We don't have enough behavioral health providers. The Deloitte study that was done in 2015 in Kentucky showed us to be significantly short of the number of providers. By 2025, the vast majority of psychiatrists in the state are slated to retire, something like 35%, I think. Most geographic service areas are somewhere in the area of 100 to 150 FTE short of having enough providers to take care of those individuals who are providing healthcare services to everybody else. So you've got to figure out how to increase the supply because the demand is still far exceeding it. So we've got to get people to the place where they want to do that. But then you have the behavioral health providers that are burnt out. We're tired. And this is my 17th, almost 18th year of practicing as a psych NP. And there aren't enough of us to go around. You know, when I'm tired, who picks up the slack? I wonder what's going to come after me. So we've got to increase numbers.
I agree. Dr. Locke, what about you?
I agree. I know the other thing I would add, and I don't know, this is probably controversial, but I know in our clinic, we have a hard time finding providers that'll take Medicaid. And, you know, we have like 38% of our service line are, I mean, they have Medicaid. And a lot of times it's frustrating, you know, because, so what we ended up doing, well, actually, one of our nurse practitioners was already in a psych NP program when we hired her. And so now, at least one day a week for our patients, you know, she does behavioral health, which has been really helpful because otherwise I don't know where we'd send people. You know, they go to what used to be comp care. Well, that's all well and good, but I've learned, you know, they see a counselor first, and then that person decides whether or not they get to see somebody that actually prescribe their meds. So, you know, so as a provider, I get frustrated with that.
And I would add on to that, Dr. Locke, and say, because there's such a scarcity of providers, they have the opportunity to pick and choose who they see, whether we like it or not. By not taking Medicaid clients, that's cherry picking who you see. You're cherry picking the patient that's going to be able to pay their bill. You're cherry picking the patient that's, you know, going to have good insurance coverage, and you're leaving those people with the greatest need without that coverage. So until you increase the supply of providers, which makes the competition a little more fierce, you're going to have a hard time driving that change.
Right.
That's a good point.
Yeah.
Yeah. My next question is about trust. You know, in any kind of healthcare relationship, trust is very important. There seems to be some kind of a, I don't know, some kind of a trust issue, particularly in rural areas and maybe with farmers as well. What can we do to build that trust with our rural patients? Dr. Locke, I'll start with you.
Well, I think you have to get to know people, and you have to be in the community, and you know, just be there. And so people don't just see you as somebody that goes to work, sees patients down there, and then goes home, and you're not part of the community. You know, we one of the things, you know, Wilmore is one of those places that the government doesn't call it rural, but it is. If you've ever been to Wilmore, I mean, there's not much else there other than, you know, a grocery store and a drugstore and, you know, a little historical area, and that's about it. But they have, you know, a Christmas thing where everybody comes downtown. They have Halloween stuff. And so we've tried to be there for that, even though that may sound kind of silly. You know, we've tried to be there for that, and we hand out cookies and all that kind of stuff. You know, we've been, and so I think, and then plus our staff live there, and that helps. So they know people that we don't know, but they're the ones that'll get patients to come to the clinic because of that. The other thing I thought of in rural areas, especially in Kentucky, is AHEC, you know, the Area Health Education Centers, because they know a lot of people. You know, they're local, and you know, I would probably recommend any provider in a rural area, you know, get to know those people.
So again, it's about getting more providers into those communities. Dr. Estes, what about you?
Sometimes it's about creatively thinking about how can you get them used to technology. You know, I use the example that patients don't like to feel like it's the only option. They want to feel like they still have a choice in that process. And so when you want them to trust something, you've got to, we would, in the psych world, we would call it progressive desensitization, where we slowly broach the topic or the exposure, and then we work them up to what the full goal is. And so maybe not going in all or none with a particular technology, but maybe exposing them to it over time. You know, when we saw you in person today, maybe the next 3 times we're going to see you, you know, via video technology, and we're going to use it this way. Or, you know, I'm going to be at that location in person. Would you like to come see me, you know, for those in-person visits? So you've got to figure out how to get that buy-in, because that's really how you work on motivational change.
Yeah, the other thing I was going to say too, sort of along those lines, is, you know, to see people more often. You know, it's hard to really get to know somebody if you just see them once a year or just once in a while. Just so, because I think people don't always think about that they need primary care. You have to explain to them what primary care is, and that it's helpful. You know, I'd much rather have you come in every 3 months for a little bit. Let me get you situated with your medicine and all. And then, you know, if we want to go to every 6 months, that's fine. But then we know each other. I know you, I know your family. I think that helps.
Mm-hmm. I agree. And, you know, especially these practices that see a patient every 10 minutes, that doesn't help develop that trust either. Yeah. With smaller hospitals closing in rural areas, will we see more areas like the one in the film? And if so, what kinds of technology, especially that you were talking about, Dr. Estes, might help alleviate these so-called healthcare deserts? And then when we talk about the technology, will we see more inequities also based off of that technology? So it's kind of like a two-piece question. I'll start with you, Dr. Estes.
So for those of you all that don't know my background, I'm actually from Hancock County, which is close to Davis County, which is where Owensboro is. So I would have historically considered myself rural in terms of Kentucky. I would have considered Eastern Kentucky rural. However, I will tell you that there are areas of Hancock County that still do not have running water. There are areas of Hancock County that cannot get internet. I live in one of those in my home in Kentucky. And so the things that are allowed for people who are in urban areas, you know, cell phone access, internet access, that allow the development for those are going to hinder counties like mine. You know, I think I said before, my county doesn't have any physicians. We don't have any urgent cares. We have 3 clinics. At the time my clinic was open, we had 3 clinics that were run by APRNs, and that's it. You know, the closest hospital to us is 35 minutes down the road. You know, there's not anything in between, but you can't grow if you can't get decent internet because you can't use any of that technology because you don't have cell coverage, you don't have internet service. So then you're limited. So then those patients that are disadvantaged anyway can't get what they need because they don't have the technology. And so somebody has got to have that infrastructure. So I jokingly say, if you've ever been to Frankfurt, have you ever seen the internet map that hangs down in the legislators' hallway where they show all of the broadband access that exists in the state? So every time I see it, I want to laugh because it's so inaccurate. I think what they did is they said that there was a high-speed fiber that at least ran through those counties, but what they didn't see is that none of those high-speed fibers were ever accessed, so they never got to the rural areas, so there's really no growth and development. So you've got to change that piece because they're not going to get it. You know, the other thing is we have to make things that are affordable for people. And I'll use the example Dr. Luck can probably talk more about. Have you ever educated a patient with diabetes that has a single grocery store in their county and they can't buy fresh fruit and vegetables because they can't simply afford it, that all they can afford is the mac and cheese in the box? It does zero good to educate them on a low carbohydrate diet if they can't afford anything other than ramen noodles.
Yeah,
that's
right.
That is true. You saying that reminds me, I remember having a student years ago, and she talked about how, because she lived in southeastern Kentucky, and she said, you know, for one thing, it was more expensive to buy healthy food than it was, you know, unhealthy food. But the other thing I was going to say about technology, it's, I think it's great. Like telehealth has been great during COVID. And I think it's still here. I think it's here to stay. But I also think it's hard to, you still want to see patients hands-on. I think of people like patient I have that has bad COPD. Well, you know, unless I've got some, if he's got some kind of way that he can put a stethoscope on his chest and let me listen to him, I need to see him. I'd prefer to see him every time rather than do telehealth. But during COVID, that was kind of all we had. So I think, yeah, there will be, you know, inequities because people can't, and health systems probably can't afford the technology you'd have to give all your patients to be able for them to get their blood pressure, listen to their heart and lungs, all that kind of stuff to really do telehealth like that.
You know, with these movie nights, we keep talking about the way things are interlinked, and you know, there's a lot of discussion about infrastructure these days, and this kind of falls within that. We need to build the infrastructure for people to be able to access the technology like telehealth or anything else that we might see coming down the line. So I think this is just a great way of showing how things are just interconnected with health and everything. Well, we'd like to open up our questions to the audience. Eleanor, you want to facilitate that?
I certainly do. Thank you. What a great discussion, Teresa. And our Sharon and Jessica, you guys have been absolutely wonderful. We have a lot of comments in the chat box, and I personally wrote at least 6 questions myself. So you guys may be in trouble. Okay, so Dr. Huber says, I agree with Teresa's remarks. My question is who's taking care of the providers? Yeah. Who'd like to respond to that?
So I'm going to use a personal example. You know, as a behavioral health nurse practitioner, who do I see when I need to be counseled, when I've had a rough week or a rough year or professionally I'm struggling? I can't go to my colleagues because my colleagues are my referral system. So then I have that professional interaction that is going to violate a boundary. What do I do? You know, and I've had that conversation. Who do you talk to when you're the expert? Mm-hmm. And we do a terrible job. We do a terrible job of that. We're not taking care of healthcare providers. Mm-hmm. I can't remember one time in my years as a nurse on the floor or working in long-term care that my boss said to me, hey, you're really stressed out. Maybe you should use your EAP benefits. Maybe you should go talk to somebody for your 6 free visits. We didn't do those things. We have to start doing it. That has to be part of the conversation.
Yeah.
I would just like to throw out there that, you know, that KNA has a Kentucky Nurses Helping Nurses program. And we have resources on our website, not only for support, but we have 120 nurses who have volunteered to be peer listeners. And I don't think that we've gotten a lot of traction yet, but I anticipate that that will happen as we wind down this COVID stress points that we have going on right now. Also, the ANA, with the ANF, the Foundation for American Nurses Association, has a program that that has expanded all over the United States for nurses to be able to use the website and also access nurses. So as you said, Dr. Estes, one of the things we haven't done is we haven't shared the access in those programs that can be accessed by other nurses.
I want to make a comment too. You know, we know that nurse suicide is higher than the general population. So, and it's been that way for a long time, and our profession hasn't really addressed that efficiently. So we do need to do a better job of taking care of ourselves.
If you want to look at some interesting data, you should also look at the occurrence of antidepressants and anxiolytics being started on nursing students while they're in the program. Those numbers will stagger your mind.
Wow. Teresa, do you want to mention some of the programs that have been offered by KNA this month to support nurses?
Well, we've had the QPR training that kind of discusses, you know, how you approach someone and help them seek help in a professional, and it's been shown to work. So it's just not something that you just pull out of your head. It has been shown to work. We also have had mindfulness training. And then Dr. Janie Heath did a talk about, you know, nurses and nurse health and nurse suicide. So the KNA was very good about providing free CEUs regarding this issue. And we know that the governor, you know, signed a proclamation proclaiming the month of May as Nurse Suicide Prevention Month. So he recognizes the issue that we're facing as well.
Dr. Locke, it looks like that you had a comment. Would you like to make a comment?
Yeah, so as I watched the movie, I was just struck by how passionate all of the providers were about what they did. I mean, they probably would have done it for free. And, you know, they just really felt strongly about what they were doing. And when Chris's wife said to him, that was when the ECHO program was beginning. They thought that was going to be going by the wayside. And she said, you know, how could you work any harder? I mean, he was already working as hard as he could, you know, but in his mind, he's like, I'm sure he felt like he could work harder. He just, you know, if he could just work harder, things would be better. And I think a lot of us feel that way. You know, we just, and you know, people my age were not brought up to think, oh, you know, if you're stressed, you're stressed. You know, that was sort of how I was brought up. Okay, yeah, it's stressful. You know, you go home, you go to bed. You know, maybe you have a glass of wine, and that's it. You know, you don't. I never, maybe the last, you know, in the last 10 years, maybe thought about even talking to anybody about it.
Yeah, reaching out.
So I think it, like what Jessica said with the students, I mean, if there ought to be a way, and we really need to be paying attention to that, and get them used to knowing that mental health is important and what they can do.
Dr. Estes, would it be appropriate for you to mention something that the KBN is working on for nurses in the future?
So there is a task force set aside to draft some administrative regulations to look at one-time suicide training for suicide detection training for current licensees, and then to potentially embed that training into all of the nursing education programs in their curriculum. We anticipate, if the work group is able to get the work done, bringing it to the full board perhaps in June, which of course will be after my tenure at the board. I will, however, be in Kentucky for the June board meeting and there. But that is on the table currently. I don't know what it will look like in terms of the draft because I'm not participating in the process. But that was the discussion at the education committee meeting a couple of weeks ago.
Thank you very much. We have a comment from Elaine Shearer. Elaine is from North Carolina, and she's joining us tonight. She's joined us for many of our series movies. She wants to know, where is Kentucky on full practice authority? Do you think that COVID will help push this along?
Let's see if Dr. Estes can tell us on that one.
She's biting her tongue.
That's a baited question if I ever heard one. So the rest of my story should be, prior to stepping into my role as the executive director at the Board of Nursing, I am the immediate past president for the Kentucky Association of Nurse Practitioners and Nurse Midwives. And so have had the opportunity to be on both the regulatory side of the fence and the professional association side of the fence. And so full practice authority in Kentucky has been part of my work for the last decade. So I've been working on it for 10 years. So there are a couple of things to know. So as in my role as the executive director, I did something that was incredibly risky. I was one of the first 6 states to abdicate collaborative agreements. We at the last minute, in the last session, Senate Bill 150 was passed in the 2020 session that essentially gave the Board of Medical Licensure, the Board of Nursing, and the Board of EMS the ability to set aside any statutory requirements that were going to prevent us from having mobility of licensure and adequate care. So we took advantage of that opportunity and set that aside. I can tell you that looking at the statistical data as it relates to the CASPR numbers for controlled substance prescribing, there are no anomalies despite what you're going to hear from members of the legislature. There are no anomalies that have shown that the abdicating of the collaborative agreements resulted in the number of controlled substance prescribing going up across the state. There is no validation in that information. With all of that being said, the legislative climate is still going to be a struggle for Kentucky. There are individuals with legislative leadership positions that are vehemently opposed to full practice authority, and that's going to be a heavy lift. The National Council of State Boards of Nursing for the last 2 years have engaged in lobbyists of their own to assist and support Kentucky in their efforts for full practice authority. But as always, we tend to be the last to do things, which is probably the reason why we tend to be at the bottom of the pack when it comes to healthcare outcomes. So the research and data, if you were to take the CDC numbers on opiate prescriptions and overlay them with the full practice authority states, you would see a pretty interesting correlation. Those states with full practice authority have fewer opiate prescriptions written per patient than those states with restricted practice. That's pretty interesting to me. So that's all I'll say on that topic without getting myself in trouble politically.
So I'd like to ask you to say one more thing, and Dr. Locke, or you, both of you, to say something. What do you think that the Kentucky Nurses Association can do to move this along? Give us some guidance. We are here to listen, take notes, and move forward.
So the reality is nurses as a collective group have to be loud and vocal, and they have to essentially blow those legislators up, especially those that are opposed to full practice authority. They've got to hear you. And, you know, we've never been great at donating dollars to legislators. Dollars do speak, whether we like it or not. So when we're not going to donate dollars, we have to use those collective voices. And I'll go back to what I said earlier is you need that number. That sheer number of nurses speaking the same message at the same time will absolutely wear them out. And that's exactly what has to happen.
And I wonder if, and I know KNA has supported our legislation that the coalition supports it, but as a coalition, well, KNA and coalition member, I sort of have always felt like it was the coalition that sort of drove the
bus
legislation. That was who drove it. I wonder if KNA could partner with the coalition, like go in together on legislation, if that's possible. I don't even know if that's possible, but given more people.
Well, let me just say that KNA has a lobbyist as well. We have the same lobbyist, I think. And it has been the #1 priority for the Kentucky Nurses Association for the last 3 years. And we've had a lot of dialogue about that support. I think one of the things, and Donna Metter might want to have a word or two about this, is that we started a program called the Affiliates Program in January of 2020, I think. And to get more nurses, specialty nurse groups to come to the round table so that we could work together to push things like this across the finish line. Donna, did you have anything you wanted to say about that?
I think we have 12 different organizations now that are affiliates with KNA, and it's been great to have that dialogue and a lot of unity. I don't believe the coalition, if that's what, I don't believe they are one of our affiliates. Is that right, Delanor? That's
correct.
We have invited them to join with that, and are still hopeful that will happen. I think that one of the great things we did last year was our virtual town halls. We had 5 virtual legislative town halls. We had many legislators on those calls and a lot of our membership. And it was a wonderful forum for us to talk to them exactly about full practice authority. And we had some really good dialogue with them. So we are certainly on that campaign. So would love to work together more on that.
We have a comment by Dr. Julie Osage. It says that this is not out yet, but the results of the University of Kentucky College of Nursing study in the fall of 2020 showed that while collaborative agreements were suspended, 130 APRNs in Kentucky, or 30% of those who took the survey, were able to accept new patients into their practices. In addition, 59 APRNs were able to accept insurances that they were not able to accept with the collaborative agreements in place. That's a lot of Kentuckians accessing healthcare. Support getting rid of the Kappa CS agreements. So good.
I agree.
The evidence supports it. And that's really the hard part, is you're really dealing with a circumstance where manipulated information is what we're considering as a truth. And there is zero evidence to support the things that we like to use as arguments in Kentucky, that the quality of care is going to go down and the number of opiate prescriptions are going to go up, and that, patients are going to be unsafe. And I've always argued the point that I've been in rooms with physicians that I wouldn't let treat my family members. Just because they have an M and a D behind their name does not mean that they're a quality provider. Quality providers are based on those individual characteristics of the provider and not necessarily the degree that they
have. I have one question, and we're getting close to the end of our time, and our moderator will take us home. But I have one question, and it's just burning. Just burning for me. And that is, with the rural issues and social justice. I heard Dr. Locke talk about, and maybe it was you, Dr. Estes, who spoke to the fact that many of these rural areas don't have access to clean water. They don't have access to broadband. Are these not social justice issues that we should be addressing? How can nurses, what can nurses do to address these social justice issues across the board?
So I'm going to go back to the answer that I gave before. Nurses have to be politically active. Who puts the dollars into internet infrastructure? The people that you send to Frankfurt.
Mm-hmm.
Who puts the dollars into clean, good drinking water for counties? The legislature. Who puts the thought process in to how much gas prices can increase in the state? The legislature. If we're not using the voices to determine who goes to Frankfurt, then we're ultimately going to continue to stay stuck where we're at.
Mm-hmm. Another thing I thought of was it John Lewis that talked about good trouble.
Yes, ma'am.
And, you know, sometimes I think we ought to just go and, you know, have a sit down or whatever, you know, in some of these places that, you know, just get mad.
Mm-hmm.
I think we, you know, if you're not living in it, you don't realize, I don't think, how what not having water, clean water would be like.
Yeah.
And I'm going to say something that might be a little controversial, but I never had a health policy class until I got to graduate school. So I think that we need to educate nurses from the beginning of how important it is that we really make our over 4 million voices heard regarding policy and regarding these social justice issues.
Well, Moderator Villaran, we are now at 9:11. You only have 4 minutes to close us out.
I can do it.
Thank you very much.
All right, so June 24th will be our last intersection of social justice and healthcare movie night. We will be watching a discussion and discussing A Dangerous Idea, Eugenics, Genetics, and the American Dream. It's a great documentary, and it's going to really create a lot of dialogue. It's a longer documentary, but well worth watching it. So we'll start at 6:30 p.m. on the 24th of June. I want to thank you all for being on this journey with us for our social justice movie nights. I hope that these events have clarified the nurse's role in social justice, equity, and inclusion. And I hope your ideas and discussions continue past June when we have our last movie night. So thank you all. We appreciate you.
Thanks. Bye, everyone. Thanks again.
Thanks, Dr. Estes. Thanks, Dr. Locke.
Thanks, everyone. Thank you.
You guys were great.